In today's video, we have an evidence-based guide to radicular low back pain and our friend, the disc herniation. Let's do it. Before we really get going, I have an absolutely free cheat sheet for you. So it is an evidence-based guide to radicular low back pain. It's a PDF. It's got a couple pages in it, and it goes over all of the key points of this lesson today. So go ahead and download it. I'll put a link in the show notes in the description and follow along. This is also very useful if 3 months from now you have a patient that walks through the door with radicular low back pain. You're like, man, what the heck did Dan say about X, Y, and Z? Just pull out the cheat sheet. You'll get it, review it, and then you're going to ace your examination with your patient. This is part 2 of our series on radicular low back pain. If you haven't checked out part 1 yet, I recommend going back and checking it out before you continue. So, what the heck is the job of the discs within our spine? So, if you think about someone squatting or deadlifting, the jobs of the discs are to take that compressive force, the force that's going straight down and smushing the spine together, and to dissipate those forces laterally. Okay. So it's a bit of a shock absorber and it helps to dissipate force so you don't have so much stress going directly down in the spine. So let's go over some definitions of disc herniations, bulges, et cetera, et cetera. And I got to tell you, I think I've been using the wrong terminology for a long period of time. And when I was reading through a lot of this medical literature, some folks would call a disc herniation where the inside contents already leaked outwards, right? There's different terminology for herniation versus bulging. So I thought this study by Fardin et al. In 2001 did a really good job of defining a bulge versus a herniation versus the contained and non-contained, like we talked about previously. And here's what the definitions were. In terms of a herniation, Fardin et al. 2001 defined it as a localized displacement of the disc material beyond the limits of the intervertebral disc space. So the nucleus, cartilage, fragmented apophyseal bone, annular tissue, or any combination thereof going beyond the limits of the intervertebral disc space. And if you look at the herniation image on the right, you can see it's kind of a focal herniation, right? So it's just a small bit poking outside the limits of that disc. Now, if you look at the disc bulge, which is the image right above that, and defined as disc tissue circumferentially beyond the edges of the ring apophyses, I'm not sure if I'm saying that right, apophysis may be described as a bulging disc or bulging appearance and is not considered a form of herniation, okay? So the disc bulge, looking at the image above, you can see, yes, it's kind of beyond that ring, but a lot of it's beyond that ring. So looking at the definitions of it, the herniation just seems to be much more focal, whereas the bulge looks a lot more broad. Now we can go ahead and further define a disc herniation as well. So if we have damage from the inner wall all the way out to the outer wall and we break through to the outside and the inside contents leak outside, that's known as a non-contained disc herniation. And these are the ones that probably hurt the most because they cause so much chemical irritation on those nerves. Now, if you have damage to the annular wall, but the last wall on the outside of the annular wall is still intact, that's known as a contained disc herniation. And these ones, you can still have mechanical compression up against nerves, but you probably don't have that chemical irritation that causes a whole bunch of pain. Like I said earlier, these herniations are usually going to be occurring in a posterior lateral direction, so back and to the side, just because that area tends to be the weakness and there's no support from the posterior longitudinal ligament, okay? Like I said previously, this ends up being a problem in a lot of folks because that herniation is pushing right into the space where the nerves live. And if you have the inside contents leaking outside, you get that chemical irritation, lots of inflammation, and all those terrible symptoms your patients talk about. So let's define radicular low back pain. Radicular low back pain is defined as compression or chemical irritation of the nerve as it exits the spinal cord. Now, this can actually happen in a variety of different regions, and I have an image here just to show you. So the compression can occur at the thecal sac, which is the sheath or tube that surrounds the spinal cord. So think about the spinal cord. The first thing it travels through is that thecal sac, and you can have compression right at that area. The next place you can have some compression is going to be at the lateral recess. And this is bordered laterally by the pedicle, posteriorly by the superior articular facet and ligamentum flavum, and anteriorly by the vertebral body, end plate margin, and the disc margin. Okay. Lastly, we can have compression at the neural foramina, and this is basically where the nerve exits the spine. And if you look at our image here to the right, you have your central canal, and the thecal sac is where it exits from that. The thecal sac surrounds the spinal cord, and the nerve exits. You can have compression right there. Right outside of the thecal sac is going to be the lateral recess. And if we keep going laterally, then we have the foraminal space. So, largely, radicular low back pain is usually caused by a disc herniation. So, it's just like we talked about a bulge or a disc herniation, herniation pressing up against that nerve or having some of the inside contents leaking outside, right? That's the most classic way to get radicular low back pain. You can also get radicular low back pain due to spondylosis, which is narrowing of the spinal canal, neural foramen, or lateral recess. And this is just due to degenerative osteoarthritis. You also have facet or ligamentous hypertrophy, spondylolisthesis, or even neoplastic and infectious processes, right? So some of the ligaments can end up getting bigger, right? The facet joint gets a little bit bigger due to degeneration and crowds the intervertebral foramen. The other piece we want to be on the lookout for that is definitely something you need to refer out if you, suspect that is going to be a neoplasm, so some sort of cancer. You can also have a lot of radicular symptoms due to an infection in that area locally. The last and maybe the most serious cause of radicular low back pain is going to be not hitting the like button and subscribing to the channel. So if you hit the like button and subscribe, you're probably much less likely to develop radicular low back pain over the course of time. So when patients get an MRI and they try to read it, it looks a lot like Chinese, right? Unless you're actually from China, then, it's going to look like some other language you don't know. But it's very complicated. But having going over all the definitions and showing you some of the anatomy, let's try to make some sense of this. So this is just an MRI that I have for one of my recent patients. And what it says is at the L4, L5 level, there is diffuse disc bulge. We know what that is, causing mild, so not that much, bilateral, both sides, neural foraminal narrowing. So the space where the nerves exit, it's gotten a little bit smaller. There's mild bilateral, so a little bit on both sides, articular joint facet hypertrophy. So we looked at the facet joint previously, and you could see how close it was to the intervertebral foramen and can cause some narrowing as a result. And this contributes to produce bilateral, so both side, neural foraminal narrowing. Okay. At the L5 S1 level, there is diffuse disc bulge with posterior central disc protrusion. So think about the disc bulge compared to the herniation. The bulge is going to be a little less focal, right? More broad with a posterior, so on the backside, central disc protrusion. So basically, there's a protrusion centrally located, and we'll talk about what a protrusion is in a minute, causing mild anterior thecal sac deformity. So we know what the thecal sac is. Looks like the disc bulge created an anterior thecal sac deformity, so pushing up against the thecal sac, contacting the traversing nerve roots bilaterally towards the subarticular zones. Additionally, there is a posterior annular fissure. So a fissure is just part of the annular wall being broken. The disc bulge is contacting the exiting nerve roots at L5 bilaterally. So the disc bulge is coming up into contact with the nerve roots of L5 on both sides. There's mild articular joint facet hypertrophy, so only a little bit of hypertrophy of those facet joints. And that's contributing to produce bilateral neuroforaminal narrowing, okay? So when a patient gets this information, they think that their spine is completely messed up, right? There's so much confusing stuff here. And I think if you can read some of this to your patient and just explain to them what the heck is going on, then oftentimes that's actually quite helpful and they know exactly what's going on. And all these big words don't mean there's anything dangerous. They're just using a lot of medical terminology, and you can really simplify it for them. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the fitness pain-free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning. So we actually have a bunch of different types of disc herniations, right? So we went over the difference between a herniation, more focal, and a bulge, which is much more broad, okay? So these are herniations and they're much more focal. And you can have a protrusion, an extrusion, or a sequestration. When folks have a protrusion, it means that the base of the herniation is going to be larger than the head, okay? You can see that image on the top right. In an extrusion, it's the opposite. So you have a herniation where the head is actually bigger than the base, okay? And in the final version, we have a sequestration, and this is usually the most serious of the injury. So what happens is that material came out and it detached, right? So you had disc material and it came out, it bulged, it herniated, whatever, and it completely came out, detached from the rest of the disc, and now is sitting in the intervertebral foramen. And I really think this next stat is helpful for patients because a lot of these things can be very scary, especially the sequestration. If someone knows that's going on in their spine, they're like, what the heck? I don't know what to do. How do we get that thing out of there? That sounds really bad. And this is actually quite cool. And this was a study looking at spontaneous recovery of lumbar disc herniations by Chun Chia et al. 2014. So the rate of a herniated disc becoming smaller over time was 96% for sequestrated discs, 70% for extruded discs, 41% for protruded discs, and 13% for bulging discs, right? So what the takeaway here that I think is really hopeful for patients is that the worse the disc herniation is, the better your body is at cleaning that up. Okay. That ends up being a really powerful and beneficial thing, obviously, and patients love to hear that. I think the flip side of things is that patients will ask, well, if I have a protrusion or bulge, how come that's healing? Not healing, excuse me. Well, I can't answer that for you. I can only guess that if you have, let's say, a small bulge or you have a small protrusion, your body might not have to do anything to heal it per se, just because the damage is not maybe great enough to cause an injury. And if it did, there's plenty of space in that intervertebral foramen. If I have a little bit of a bulge just poking into the intervertebral space, it might mean I still have a ton of space within there. So I don't necessarily have to shrink it, from a body perspective, right? But if I have a big old sequestrated disc and there's a whole chunk of disc in that intervertebral space and it's really crowding out the nerve, your body's like, whoa, this is a problem. Let's shrink that. Let's get rid of that piece, right? So here's an MRI of the spine. We've sliced the spine right down the center just to orient you a little bit towards the backside, right? To the right of this image is going to be the person's back of their body. So think about the spinous processes that stick out. You can kind of feel them if you palpate along the skin. And then towards the left side of the image is going to be the vertebrae and the discs, right? And then to the front of that, so even further left, would be, let's say, like your intestines and everything else in your stomach, right? So you can see the intervertebral discs between the vertebrae, just like we kind of showed before. And I put a big red arrow where you can see a beefy disc herniation, right? And if I had to classify what type of disc herniation this is, it seems like the base is smaller than the head. So this looks a bit like an extrusion. The other piece is that it may or may not be detached, right? And I don't read MRIs for a living, so I can't tell you exactly what this is, but at least you can appreciate what's going on based upon what I told you previously. So here's a patient of mine previously, and he ended up with a pretty bad case of radicular low back pain from a good morning that was really heavy. So kind of the standard, doing the good morning, felt something kind of go. After that was, oh my gosh, this is extremely bad. Went to the emergency room, got some imaging right away. Wanted to make sure nothing serious was going on. And then maybe a couple weeks later, they find themselves in my clinic, right? Well, here's what his MRI showed, and here are the findings by level. So T12 to L1, largely unremarkable. Same thing at L1, L2, same thing at L2, L3. And then at L3, L4, it got a little bit more interesting. And there was diffuse disc bulge with mild facet hypertrophy and thickening of ligamentum flavum. No significant spinal canal stenosis. Low grade left greater than right neural foraminal stenosis. Okay. You can kind of appreciate the disc bulge coming out and contacting up against the nerves as they exit. Okay. And I tried to put this arrow based on the level so you can kind of see what's going on. At the L4, L5 level, there's a diffuse disc bulge with mild facet hypertrophy and thickening of ligamentum flavum. No significant spinal canal stenosis. Minimal bilateral neural foraminal stenosis, which is great, right? So you can see the arrow again. Looks like we have a bit of, I would call that maybe a protrusion in this area. Okay. They're not defining that. They're defining that as a disc bulge. So it's probably broader than I can see from this slice, right? And at the L5S1 level, there's diffuse disc bulge with mild facet hypertrophy, no significant spinal canal or neural foraminal stenosis, right here. Yep. And you can see sticking right out there, the disc bulge again, right? And this patient actually, I lied to you. He came in and initially didn't have imaging and later on ended up getting some imaging. So there is a good chance the body kind of took care of whatever was going inside of the body. And then this is picking up a kind of healed disc herniation, right? Although there is a chance that some of this pathology was giving him his symptoms because he's a relatively young guy, right? But it's tough to know. So here's the good old mechanism of injury that physical therapists have been scaring their patients with for years and years and years. So largely the idea is if I bend forward or round my spine, so if I go down to pick something up off the floor, especially if I round my spine would be bent, boop, this way. Sorry, my spine is pretty stiff here, so it doesn't bend well. But the idea is if I bend or flex forward this way, I will compress the front portion of the disc and it will shoot the disc contents posteriorly, right? So the idea is that you shouldn't load and flex your spine because that's going to put stress on the back side of the annular wall and create a disc herniation. The common explanation I hear from a lot of surgeons is to think about a jelly donut. So if I take a jelly donut and I squish it on one side, the jelly squirts backwards, right? In the case of the disc, potentially posterior laterally, and you shoot the inside jelly outside and you bathe those nerves in jelly inflammation, right? And here's the thing I purposely didn't really delve into the medical literature for quite a period of time about spinal flexion causing injury because it's just a huge can of worms. But I do want to give you the history, right? If you're not really up to date. And I also recommend you go back and read some of the literature. Just try to figure out for yourself whether or not spinal flexion or spinal flexion under load is actually dangerous. So I think the person who ended up making spinal flexion, especially under load, a scary thing was probably Stuart McGill. And I tell you what, I really like Stuart McGill. I'm not trying to throw him under the bus whatsoever, but I think all the hubbub probably started when he had his books and he wrote his research, back in the day. And what he did was he took dead spines, right, from pigs initially. Subsequent research was done in pigs as well as sheep, right? Keep in mind, human beings are not sheep or pigs, and that's one of the reasons why folks are a little skeptical of his findings. And what they did was they subjected the spines to a tremendous number of repetitions of either compression, right, or compression with flexion at the same time, right? And they do thousands and thousands and thousands of repetitions, and they just take note of when they have an injury and how many injuries they have, right? So Stu McGill's initial research found more disc pathology in the group that combined compression with flexion. I think the other thing to keep in mind is that he found a bunch of different types of injuries. So he found disc herniations, right, from this experiment, but he also created vertebral end plate fractures, and he actually had some spondy injuries as well, right? And the important thing to keep in mind is that it's not like the compression group in a neutral spine position had zero injuries, and the compression with flexion had a ton of injuries. They were very, very similar. Okay. So it's almost the same amount of disc herniations in one group versus the other. However, there were more disc herniations in the group that added flexion with compression and not just compression alone. So that's one of the reasons Stu McGill has said that it could be dangerous to try to lift heavy loads if you're not trying to stay neutral. If you're allowing your spine to flex, flex, flex under heavy, heavy load, right? Particularly when you lift the weight off the floor, if your spine starts to flex at that point, his thought was, all right, that's what's going to end up causing an injury. We should try to stay neutral. Okay. It's also important to understand that in subsequent research, a lot of this was actually performed in sheep spines. It didn't show this. It's not like the flexion and compression model had more injuries. They didn't find it. It was the same amount of injuries in flexion and compression versus just compression. What I should also mention is that we talk a lot about flexion being bad for the spine, but if we're looking at some of these studies, when they add torsion or rotation or twisting to the spine, it actually increased the failure rate as well, more so than adding flexion. So if we're going to be scared of anything, I would choose rotation over just flexion. At the end of the day, we're not pigs, right? We're not sheep. No one goes in the gym with a limp spine and does 40,000 repetitions of crunches over and over again with the weight on top of their head. Okay. Doesn't make a whole lot of sense. So, the other piece is that human spines can potentially adapt. And we'll talk about the research about this a little bit later. But when we go in the gym, how many reps of flexion and compression are we doing? 40, 50, 60, maybe 100, right? And it's sometimes with a heavy load, sometimes with a light load. We rest afterwards, right? So we're not subjecting our spines to 40, 50,000 repetitions. We're not doing it with a completely limp spine, okay? The other piece is that our spines can adapt over the course of time. So a lot of folks have kind of said lifting with a rounded spine doesn't matter. You can adapt over the course of time, right? And I'm not sure that we really fully understand that yet, but it does make sense in theory. What I will say is I highly recommend you go and look at some of these studies. I've left the links in the show notes. Read through them yourself. Use your brain a little bit. You can kind of come up with your own conclusions on whether or not lifting with a spine that's flexed is bad for you. The next question we have is that does lifting with a flexed or rounded spine increase stress on the disc? And we actually have a few studies that can help guide us here. So Lee JQ did a meta-analysis in 2022 looking at intradiscal pressures of folks either standing or sitting. Okay. And the reason why sitting versus standing is when you're standing, the spine is in relative extension, at least the lumbar spine. And when you sit down, the spine is in relative flexion. So in theory, if flexion increases stress on the spine, increases the intradiscal pressures, then sitting should actually be a little bit more stressful on those discs. And what they found is that largely sitting in a flex position is a little bit more stressful on the spine than standing, at least from an intradiscal pressure standpoint. However, the research is mixed on this. So this study was a 2022 meta-analysis, and what they said is that studies before 1990, there's a clear correlation. So largely, if you sit in a flex position, increases stress on the disc, right? But studies after 1990 found no difference. And I can't tell you exactly why this is. I'm not sure if they were, the study was done a little bit differently. The way they measured it changed. Did the technology change? I really don't know. What was also very interesting is that once you have a degenerative disc, right? So if you think about the disc of an 80-year-old versus that of like a 10-year-old, the 10-year-old, if they sit and flex, maybe that increases the pressure within the disc. But once you're 80 and you have degeneration, there's no difference anymore sitting versus standing, right? And the other piece to keep in mind is this actually varies based on the disc level. So L1, L2 versus L3, L4 versus L5, S1. So there's a lot of variance in intradiscal pressure sitting versus standing. It's not as simple as when you sit, the pressure in all of the lumbar discs goes up, and when you stand, all the pressure goes down. Okay. The next question we can start to ask and then answer is that does flex spine lifting cause or perpetuate low back pain? So a couple people looked at this, mainly Saraceni et al. In 2022. They were looking at manual laborers with a history of low back pain, and they found that those folks actually lifted with less spinal flexion. And they also lifted with more of a squat pattern, and they went a little slower, right? And this makes sense. So in my mind, if you've had back pain in the past, you're probably going to choose a lifting technique that puts a little less stress on the spine. So if I'm going down to pick something off the floor and I bend only at my hips, yes, I'm going to put more stress in my spine and into my hips, right? If I bend my knees and get a little more upright, I'm now sharing some of that load with my legs a bit, right? Now, I don't know why these folks tended to lift with less flexion. There is a bit of research to show that folks that have had low back pain in the past, they typically lose flexion. Maybe they hurt in flexion at some point, so they adapted more of a neutral or kind of a stiffer position. Hard to know. But at least in this study, the folks that had low back pain, they actually tended to live with more of a neutral spine and more legs compared to folks that didn't, right? So hard to know. Did these folks live with that technique prior to injury and that's what hurt them? I don't think that's the case. But those without a history of low back pain, they're not lifting with a neutral spine and knees forward using their legs. Another study by Saraceni et al. In 2020 showed that there was low quality evidence that greater lumbar spine flexion during a lifting task was not a risk factor for low back pain onset, persistence, or a differentiator of people with and without low back pain. So largely, folks that choose to use a flex spine position when they pick things off the floor doesn't mean they're destined for low back pain, at least based on this study right here. The other piece they looked at is if you currently have low back pain, if you choose to keep lifting with a flex spine, it doesn't seem like that's going to make your pain persist any more than lifting with a different strategy. So, at least based on this research study, it doesn't seem to make a difference if you lift with a rounded spine or more of a neutral spine and your risk of having low back pain in the future. And this is the craziest thing that Saraceni et al. Found. And they found that not hitting the like button or subscribing to the channel increase your risk of lumbar disc herniation by 5-fold. That's crazy. Better hit that like button. So this kind of brings up the question that can herniated discs heal and adapt, right? So going back to our anatomy, the top and the bottom of the discs are going to be the superior and inferior end plate. The annulus fibrosus is a stiff material around the edges, and you can see there's layers, right? The inside is the nucleus propulsus. Inside of the disc, that's a soft material. So here's the thing. We had said the spine is built to dissipate forces. The discs in particular are designed to dissipate forces laterally. So what ends up happening is that inside the nucleus propulsus, there are high pressures. Because of these high pressures, there's not great blood supply. So the thought is this area doesn't heal very well at all, right? What's kind of cool is that the rest of the disc can actually heal. So both the vertebral end plate, so think about the roof and the floor of the disc, can both adapt to stress, as well as the annular wall. So the outside periphery of the annular wall has some blood supply. It can actually heal and it can adapt over the course of time. Now, this is great news because what helps things heal? Applying stress, right? We can actually beef up the disc as well as the vertebral end plates by loading the area. Now, this study was saying that moderate stress is what's going to help you out here. What the heck does moderate stress mean? I don't know. I don't think that we've really formulated what the best type of stress is or the best dosage of stress is for the spine to get the results that we want. I don't think we have good research in terms of how long it takes for these things to adapt over the course of time. I'd love to know that because that would be pretty good. We can start to determine how much loading we have to do and when people can start to subject themselves to heavier loads over the course of time after an injury. And maybe if you're a new lifter, how long you have to go kind of light until you can start to push things a bit more so we can try those adaptations and get a nice beefy annular wall before we subject ourselves to super heavy loads, right? So I think that ends up being the big question mark. Does exercise help these things to adapt? Yes, it does. But do you need 315-pound Jefferson curls in order to make this thing adapt? I don't know. Maybe. At least in my mind, we probably just want a moderate amount of stress, moderate loads, right? Moderate set and rep ranges, moderate exercises. So Jefferson curl, maybe it's perfect, maybe it's too much. Hard to know. Your guess is kind of as good as mine. So now that you have some evidence-based information about radicular low back pain, you still need to know how to treat these folks. Well, I have a case study for you where I break down a patient with radicular low back pain, show the exact treatments that I use, and show exactly how he got back to weight training over the course of time. I'm going to leave a link up here. You should go ahead and click on that and continue with the learning. Lastly, I just want to say thank you so much for your support. You truly allow me to do what I love for a living. If you're watching this on YouTube, please hit that thumbs up button. If you leave a comment, it helps the algorithm. I'd also love to know your thoughts on this presentation today. Please subscribe to the channel, it helps me out tremendously. If you're listening to the podcast version of this, please consider leaving me a positive review. Again, it helps tremendously. If you want to see more content like this in the future, we got to make sure we grow this over the course of time, right? And lastly, if you want to support me even further, consider subscribing to Fitness Pain Free Insiders. This is going to be my premium subscription membership to Fitness Pain Free, where all my best content updated monthly lives. So head to fitnesspainfree.com, click on the programs link, click on Fitness Pain Free Insiders online library, just $1 for a week trial. I'll also leave a link in the show notes in the description. All right, go ahead and check it out. And lastly, I have all of my references, and it's a god awful amount of references. And I know you can't read any of this. So if you really want to check out the references that I used, I recommend checking out the show notes, link in description, and you can see all the references that I used. And if you like them and you want to comment on them, leave a comment.